Welcome to part one on the alterations in cognitive systems, and we'll be going over cerebral hemodynamics and motor function as well. First, starting off with alterations in cognitive systems. We know that there are three systems that support our cognitive function. We have the intentional systems, the memory and language, and the affective, or sometimes called the motive system. When we use the term consciousness or full consciousness, this is the state in which we have awareness of ourselves and the environment. And this also will include the ability to respond to external stimuli with the wide variety of responses. Now, consciousness has two components. We have the state of awakeness, which we call arousal, as well as the content of thought or awareness, and this encompasses all the cognitive functions. We also need to think about the reticular activating system, which is called the RAS, and this is a diffuse network of nerve pathways in the brainstem which connect our spinal cord to our cerebrum and our cerebellum, and it mediates the overall level of consciousness. What can alterations in arousal be caused by? Well, we have structural alterations that are divided according to the original location of the pathologic condition. We use the landmark, the supratentorial, which is meaning above the tentorium cerebelli. We use the term infratentorial, and this is subtentorial, which is below the tentorium cerebelli. If you forget where the tentorium cerebelli is located, please look that up in your textbook. We also use the terminology subdural, which is below the dura mater, extracerebral, which is outside the brain tissue, and intercerebral, meaning intra means within the brain tissue. Causes can actually include, now this is causes to structural alterations. These are things that include infection, vascular alterations, neoplasms, traumatic injury, congenital alterations, degenerative changes, metabolic disorders, and even polygenic traits. The other type of alteration is a metabolic alterations in arousal, which produces a decline in our arousal by alterations in the delivery of our energy substrates. And this can occur with hypoxia, electrolyte disturbances, as well as hypoglycemia. There are other metabolic disorders that are caused by our liver or even our kidneys that cause alterations in our neuronal excitability because of failure to metabolize or eliminate the drugs and the toxins through the liver or the kidney. And all the systemic diseases that eventually produce nervous system dysfunctions are part of this metabolic category. And lastly, we have psychogenic alterations in arousal. This could be an unresponsiveness. Now, though these are less common, they can signal general psychiatric disorders. And despite apparent unconsciousness, the person actually might be physiologically awake, and the neurologic examination could actually come back as having found normal responses, all falling under psychogenic alterations. An altered level of arousal occurs by diffuse bilateral cortical dysfunction, bilateral subcortical dysfunction, and this is like reticular formation or at the brainstem, or localized hemispheric dysfunction in metabolic disorders. What we would see clinically is a change in the level of consciousness, and really they can diminish in stages from alert and oriented to even confusions and to coma. So there's a wide range of stages. An alteration in breathing pattern and the level of coma reflect the level of hemispheric and brainstem dysfunction. The pupillary changes reflect changes in the level of our brainstem function as well. It also can tell us about drug action and response to hypoxia and ischemia. We can look at ocular motor responses, abnormal eye movements, including nystagmus and divergent gaze. This can also reflect alterations in brainstem function. And then the level of brain function manifests by changes in generalized motor responses, or we can have the presence of no responses. Now, vomiting, yawning, and hiccups. This is interesting. It's produced by diseases in the medulla oblongata. So infections, neoplasms, maybe there's an infarct in that area. Vomiting, yawning, and hiccups are very complex reflex-like motor responses, and they're integrated by the neural mechanisms in the lower brainstem. So again, medulla oblongata. And these responses are produced by compressions or diseases involving the tissues in that area, the medulla oblongata. Most CNS disorders will produce nausea and vomiting. But vomiting without nausea really indicates that there's a direct involvement of the central neural mechanism, or pyloric obstruction. Vomiting often accompanies CNS injuries that will involve the vestibular nuclei, particularly when someone has diplopia, which is double vision. Also, CNS injuries that impinge directly on the floor of the fourth ventricle, or they can produce brainstem compression secondary to increased intracranial pressure. You can also see that there are alterations in arousal, which we talked about, and the levels of altered consciousness that we spoke of earlier. We said that there were different states and stages from alert and oriented to confusion and coma. And you can see using this chart that the state of confusion really is the loss of ability to think rapidly and clearly. So there's going to be some impaired judgment and decision making. When you're disoriented, there's a loss of consciousness. You might have disorientation to where you are. Your memory may be impaired, or you may even have a situation where your patient doesn't recognize who they are. Lethargy can occur. Obtundation. Obtundation is mild to moderate reduction in arousal. And this will have a limited response to the environment. Your patient may fall asleep unless you're constantly stimulating them verbally or tactilely. And they'll answer questions with only minimal responses. And we would call this patient obtunded. Stupor is a condition of deep sleep or unresponsiveness, even though you're trying to arouse the patient tactilely and verbally. And they may only open their eyes by vigorous and repeated stimulation. With a light coma, this is associated with purposeful movement on stimuli. In coma, there would be no verbal response to external environment or to any type of stimuli. Now, noxious stimuli might cause some reaction to the motor movement, like deep pain or if you're trying to suction the patient. And deep coma, there's absolutely no responsiveness and there's no response to any type of stimuli. Now we're going to take a closer look at this tentorium cerebelli, and sometimes it's called the cerebellar tentorium, both meaning in Latin, the tent of the cerebellum, and it's the extension of the dura mater that separates the cerebellum from the inferior portion of the occipital lobes. And you can see it here in this schematic delineated by the red line. So first we're talking about supratentorium, and this is above the tentorium cerebelli. And these structural alterations in this area would produce changes in arousal by either diffuse or localized dysfunction. So with diffuse dysfunction, we're talking about things that are affecting the cerebral cortex or the white matter, like encephalitis. Disorders outside the brain but within the cranial vault, we call that extracerebral. They can also produce diffuse dysfunction, like neoplasms, closed head trauma, subsequent bleeding, and subdural empyema. Empyema is accumulation of pus. If it's if it's inside within the brain substance, we call that intracerebral. So we think of like intracerebral bleeding, infarcts, emboli, tumors. And these are going to function primarily as masses. In terms of infratentorial disorders, these are below the tentorium cerebelli, and they're going to produce a decline in arousal by directly destroying the reticular activating system and its pathways. And things that can do this are the accumulation of blood or pus, neoplasms, demyelinating disorders. The brain stem, which includes the midbrain, pons, and medulla, can also be destroyed by direct invasion or by indirect impairment of blood supply to this part of your brain. And the most common of the direct destruction is a CVA, or cerebral vascular disease. Demyelinating diseases, neoplasms, granulomas, abscesses, and head injury can also cause brainstem destruction by putting compression on the tissue in this area. And this can occur because of either direct pressure on the pons in the midbrain, which would then result in ischemia as well as edema, or there's some type of upward herniation or push of the cerebellum through the tentorial notch, which is a small space, and you can imagine it pushing past that tentorium. And this would compress the upper midbrain and the diencephalon. It can also cause a downward herniation of the cerebellum through the foramen magnum, which is just a small little anatomic hole, but if it pushes or herniates through that, it can cause compression and displacing of the medulla oblongata. And so when you're using this chart, you can see the differential characteristics of the disorders based on what you're seeing manifesting in your patient, the clinical manifestations. And then you might be able to deduce what mechanisms are causing it. So if there are things like motor signs that are abnormal, you might think it's some type of metabolic coma, drugs, organ system failure. If there's an acid-base imbalance, that would cause hyperventilation or even maybe hypoventilation. This is also common with metabolic coma or exogenous toxins like drugs, or endogenous toxins that can occur with organ system failure. With psychiatric unresponsiveness, what you would see manifest are things like the patient's lids closing actively, their pupils are reactive and dilated. They might have ocular cephalic reflexes that are very unpredictable, and you see nystagmus present. Their motor tone may be inconsistent, but it also could be normal. There might be regular rate of ventilation or hyperventilation, or you might not see anything pathologic at all. Usually, it's very hard to deduce if there is psychiatric unresponsiveness because many of the things that you're seeing are normal, including EEG. So how do we know if it's metabolic versus a structural complication? And structural alterations in arousal, they're divided to where the origin of the location of pathologic condition is taking place. So again, we're using that tentori or tentorium cerebelli as our landmark. You also can note here that the clinical manifestations of metabolic and structural causes are going to differ as well. So in terms of changes in cranial nerve 2 or 7, you might see with metabolically induced changes that these cranial nerve reactions would be equal, where if it was a structural indication, the cranial nerve 2 and 7 would be formed asymmetrically. Going through this, you might see some changes as well in sensation. It's usually, if it's metabolic, you're going to have more systemic causes. And so most of these responses, if you go down the list, are symmetric. Versus if it's structural, it's probably only affecting, one part of the brain or the other. And so the asymmetric responses are more common with structurally induced. So if it's difficult for you to memorize this whole chart, that is how I would try to remember that. Systemic for metabolic, and so therefore you have symmetry. And structurally, you will see more asymmetric responses. In terms of the ocular motor response, we know from health assessment when a patient has full consciousness, their eyes are going to move as their head turns. You're going to see reflexes that are normal bilaterally. You're going to see that your patient will have the extraocular motor movement intact. Their pupils react by dilation and constriction appropriately. But as we start to have more alterations in this ocular motor response, you can see things like fixed gaze. You might see more nystagmus. You can see that there might be inability to move their eyes through the 6 cardinal gazes. And what you're trying to determine too is how is this changed with resting on spontaneous eye movements versus the reflexive eye movements that we also test as well. And this will point to where the dysfunction may be. Is it in the pontine of the brain? Is it in the encephalon? Or maybe it's at the cortex? Now we're going to move on to the pattern of breathing. It's really interesting that changes in our structural function of the brain can cause changes in our breathing as well. And with normal breathing, the cerebrum, which is the neural center in the forebrain, will produce a very rhythmic breathing pattern. But as our consciousness level decreases, that lower brainstem center regulates the breathing pattern by responding to changes in our CO2 level. We have different types of patterns of breathing here. I do want to pull out specifically the Cheyne-Stokes respiration type breathing. And this is an abnormal rhythm of ventilation. So you're going to see periodic breathing. We'll have alternations of hyperventilation and apnea. We sometimes call this a crescendo, like moving upward, and decrescendo pattern. So hyperventilation, moving upward, and apnea, decrescendo. Now, in the damaged brain, higher levels of CO2 are required to stimulate ventilation and increase our CO2. That increase in the CO2 is going to lead to tachypnea. Now, as the CO2 or acid level then decreases to below normal, our breathing stops. And this is where we have that period of apnea. So again, that hyperventilation and then followed by apnea. And this occurs until the carbon dioxide can reaccumulate and stimulate tachypnea again. Now, in some cases of opiate or sedative drug overdoses, this respiratory center is depressed, and that rate of breathing gradually decreases until you are in full respiratory failure. Another type of breathing that you might pay attention to is the central neurogenic hyperventilation. And this is a respiratory pattern of sustained hyperventilation that's caused by a lesion in the central pons of the brain. So you might have what's called apneustic respirations of prolonged inspiratory and expiratory phases that are caused by the injury to the pons or even the upper medulla. We also sometimes call these cluster respirations, and this is characterized by periods and clusters of rapid respirations and then near equal depth resulting from trauma, compression to the medulla, or if someone has chronic opioid abuse. When we use the term ataxic respirations, these are regular respirations with prolonged periods of apnea associated with damage to the medulla. You can see on this chart the patterns of breathing. It does describe it very well. And then you can also look to see what the location of injury is that is causing that type of breathing. Sometimes in healthcare, we use the term agonal gasps, and this is where you have that gasping breathing pattern. It's the last breathing pattern here on this chart, and we have deep, all or none type breathing, okay, and it's very slow. And this is indicative of a failing medulla or medullary respiratory center. Please look at this chart a little bit more, see what types of disorders are associated with the breathing pattern. I would pay close attention to the Cheyne-Stokes respiration as well. For those of you that are more visual and would like to see in terms of what this might look like on a more rhythmic pattern, this is a slide for you. And you can see here with the Cheyne-Stokes breathing, this period here, this long line is apnea. We got that hyperventilation, that stop, that apnea, hyperventilation, stop, and as it keeps going. So that's the Cheyne-Stokes respiration there. You can see with the cluster, you have clusters of breathing and stop, clusters of breathing and stop, cluster of regular breathing and stop. And here let's talk about the differences in motor responses. Now, assessment of motor responses, what does that do for us? It really helps us to evaluate the level of brain dysfunction and determine what side of the brain has the most damage. The pattern of responses can be due to, or can help us note what we're looking at. So is it purposeful? Is there a defensive or withdrawal movement of limbs when you are presenting a noxious stimuli like pain to your patient? Or is it inappropriate or not purposeful at all? And this could be generalized motor movements, posturing, grimacing, groaning, with or without stimuli. Or are they unresponsive and not present whatsoever? So you have no motor response. A purposeful response is going to require an intact corticospinal system. So when there's purposeful response, we know at least that corticospinal system is working. With the non-purposeful movement, this actually will provide evidence that there's severe dysfunction of the corticospinal system. Now, the motor signs will indicate a loss of cortical inhibition, and these are commonly associated with decreased consciousness. It includes primitive reflexes and rigidity. Sometimes rigidity is called peritonia. Primitive reflexes, remembering from health assessment, these are things like grasping, reflex sucking. These are all normal in a newborn, but they're supposed to disappear in that first year of life. The motor responses that we often see are the decorticate, deliberate posturing, and rigidity. And we're going to go through all four. But the decorticate posturing, how I remember this is when you're courting someone or dating someone, you have your arms wrapped around them. And so with decorticate posturing, which is denoted here in the picture A, the individual has their hands close and over their chest. And you see the flexion here, the lower extremity extension and upper extremity flexion. When we see this, we think of hemispheric damage above the midbrain. When they have deliberate posturing and rigidity, the upper and lower extremities are both extending outward. So there's an extension response. And what we'll see is this term called opisthosnos, which is the hyperextension of the vertebral column. And your patient will have clenching of the teeth, abduction, hyperpronation of the arms, extension of the lower extremities. And this is associated with damage to the midbrain or upper pons. In acute brain injury, You might even have shivering and hyperpnea, and this can accompany unsolicited, recurrent deliberate spasms. This tells you that there's some type of acute brain injury causing the limb extension regardless of where the disease process or damage is located. Now, the extensor responses in the upper extremities that are accompanied by flexions in the lower extremities, think pons. When there's a flaccid state, so very hypotonic, with little or no motor responses, you think lower pons and upper medulla. Let's practice. A patient has a structural problem within the brain tissue and it decreases the level of consciousness. Which of the following best describes the location? So you want to think about the keywords here. It says within the brain tissue. So that gives it away. Intracerebral means within the brain tissue. Okay, remembering that subdural means below the dura, infratentorial is below the tentorium cerebelli, and extracerebral is outside the brain tissue. Therefore, the answer is C, intracerebral, because it says within the brain tissue. This term that we use in healthcare, brain death, you may hear this term just thrown out, and sometimes it is used interchangeably with cerebral death, but they're two different things. So let's first define what brain death is, and this results from irreversible brain damage, and there's no ability to maintain internal homeostasis at that point. Brain death represents irreversible brain damage, including inability to maintain any cardiac, respiratory, or vital functions in your body. Okay, so there is a criteria to follow in order to determine if the patient has total brain death. And this is, first, you need to complete all appropriate diagnostic and therapeutic procedures. There must be unresponsive coma, so there's no motor or reflex responses. There's apnea, no spontaneous respirations. The pupils must be dilated and fixed with no pupillary reflexes. The EEG will appear flat, so no brain waves. No ocular responses. Isoelectric EEG, meaning there's no stimulation of the brain. And this needs to be persistent 6 to 12 hours after the onset. Now, versus cerebral death, which we're going to talk about next. Now, cerebral death is also a state where there's irreversible coma, and it's going to represent permanent brain damage, but there's still an ability to maintain cardiac, respiratory, and other vital functions. So that difference there is important. Now, arousal can return in vegetative states and in minimally conscious states, but the content or thought processes of your patient will be absent or very, very markedly reduced. There's something called locked-in syndrome. This is important to understand too. Sometimes it's called ventral pontine syndrome, but locked-in syndrome, where there is content of thought and level of arousal both intact, but the efferent pathways are disrupted with complete paralysis. Cerebral death or irreversible coma is by definition the death of the cerebral hemisphere exclusive of the brainstem and the cerebellum. So the damage here of the brain is going to be permanent. The individual is going to be unable to respond with appropriate behaviors in significant ways to the actual environment. And the brainstem can continue to maintain that internal homeostasis, like our body temperature, our heart rate, our respirations, and even the metabolic functions. Those that survive cerebral death can remain in a coma, or they can come out of a coma or emerge into a persistent vegetative state. Or they can have minimally conscious states as well. Sometimes this can happen. In comas, the eyes are usually closed with no eye opening. When in a coma, the patient doesn't follow commands, they don't speak, and they don't have voluntary movement. Okay, so at this point, I want you to compare and contrast the brain death versus cerebral death. We're going to look a little bit more closely in persistent vegetative state, or VS, minimally conscious state, MCS, or locked-in syndrome, which is also called the ventral-pontine syndrome. So first, with persistent vegetative states, there's going to be unresponsive wakefulness. Sometimes it's also called unresponsive wakefulness syndrome. And there is complete unawareness of who they are and their surroundings, complete loss of cognitive function. The patient doesn't speak anything that's comprehensible. They can't follow commands. There is a sleep-wake cycle, so their eyes will open spontaneously. Their blood pressure and breathing can be maintained without support. Brainstem reflexes like the pupillary reflex, oculocephalic, chewing, swallowing, these are all intact, but the cerebral function is what's lost. You might even have some random movements of the hand, extremities, and head. The bowel and bladder will not function properly, so there will be bowel and bladder incontinence. And if this state persists over 12 months, recovery is very unlikely. In a minimally conscious state, these patients can follow simple commands. If you tell them to squeeze your hand, they may be able to do that. They can manipulate objects. They can give you gestures or give meaningful yes-no responses. They can have some intelligible speech. They can blink. They can smile. The reactions that you're getting, these responses, are meaningful, and they're not just reflexive like you would see in a vegetative state. With locked-in syndrome, there's complete paralysis of voluntary muscles, with the exception of your eye movement. Content of thought and the level of arousal are both intact, but the efferent pathways are disrupted. The individual can't communicate through speech or through body movement, but is fully conscious with intact cognitive function. Okay, so cranial nerves 1 through 9 are often preserved. So the person possesses vertical eye movement, blinking, and these are very meaningful means of communication because they're not able to speak. Lastly here, there is akinetic mutism, and this is worth speaking about too. And this is a neurobehavioral state where there's a severe loss of motivation to move or inability for voluntary motor responses, or it could be both. And what you will see is the inability to execute the motor functions that can move your face, provide gestures, or speech. But generally, these patients will be alert oriented. They can react to external stimuli, and they can actually follow your eyes, or the movement of your finger with their eyes, but they don't initiate other voluntary activities or movements. So it's really attributable to decreased wakefulness, motor weakness, or paralysis. And this neuropathology is different compared to vegetative states and locked-in syndromes because this involves damage to the frontal lobe or the bilateral cingulate cortex, which is a component of the limbic system of the brain. Now, alterations in awareness include the alterations in executive attention, like your ability to reason, plan, make decisions, or good judgment, to correct errors, and to have self-control, as well as memory. With a deficit in selective attention, this is mediated by the midbrain, the thalamus, and the parietal lobe structures, and this is when an individual can't focus on selective stimuli, and therefore they're going to neglect those stimuli. In terms of memory, now Memory involves both non-declarative memories or the non-conscious type memories and also the declarative memories. And declarative memory involves the learning and the remembrance of episodic memories like personal events, history, experiences, facts, and information, where the non declarative memories are reflexive, procedural, or implicit memories. They're memories of actions and behaviors. Think of like motor memory. When there's a deficit of these memories, we have amnesia. And this is a loss of memory, and it can either be mild or severe. And there's two types, there's the retrograde and the anterograde types of amnesia. When you're experiencing retrograde amnesia, this is having difficulty retrieving past personal historic memories or factual memories. With anterograde amnesia, though, these are new personal or factual memories that can't be formed. But the memories of the distant past, your patient still is able to retain and retrieve. These memory disorders can be temporary, like having a little bit of forgetfulness after a seizure, not remembering, or they can also be permanent after a traumatic brain injury or being diagnosed with Alzheimer's disease. There may only be a memory disorder, or it could be a memory disorder associated with other cognitive dysfunctions as well. Now, when you have both retrograde and anterograde, this is called global amnesia, and it's the combination of both that involves the hippocampus. We also have something called transient global amnesia, and this is when the sudden onset of memory loss lasts only less than 24 hours. And we don't really understand the mechanism, but it's associated with migraine headaches, strokes. In this memory pathway, you can see how long-term memory works in both the declarative or explicit type memories and the non-declarative or non-conscious type memories. If you want a little bit more information on this, you can also go to your textbook to learn more about this. But it is a more detailed look at what we just spoke about in the last slide. Now, we saw that alterations in awareness, this encompasses all cognitive functions. Remember, awareness, selective attention, and memory. Awareness can be caused by direct, indirect disruptions that are induced by effects from toxins, chemicals, or even metabolic disorders. Direct destruction is caused by ischemia. Indirect destruction is caused by compression type injuries. And effects of toxins, chemicals, or metabolic disorders can also alter your awareness. These are the classifications of disorders of awareness. Agnosia and dysphagia or aphasia, these are different types of data processing deficits. And with agnosia, these are deficits of recognition. And this recognition can either be tactile, visual, or auditory. And it is involving the cerebral cortex. With agnosia, for example, you may put a common object in someone's hand, and by touching it with their hand, they aren't able to identify what it is, but they are able to name it when they look at it. Do you remember from health assessment what health assessment tool did we use or technique did we use to test for agnosia? So stereognosis or stereognosia, this was a test where we have them open up their hand and close their eyes, and you put a common object in their hand, like a safety pin, a paper clip, or a coin. And they have their eyes closed, and you're trying to see if they can name what that is. Now, agnosia is produced by dysfunction in the primary sensory area or in the interpretive area, again, of that cerebral cortex, which is your temporal occipital area. And the types of agnosia and the associated area that's most commonly involved, these can be found in the table in your textbook. Although nausea most commonly is associated with CVAs or strokes, it may rise from any pathological process that's injuring that specific area of the brain. This is different than aphasia, sometimes called dysphagia. And this is impairment of comprehension or production of language with either impaired written or verbal communication. And the terms aphasia and dysphagia, they are often used interchangeably. Now, aphasia results from the dysfunction in the left cerebral hemisphere. In Broca's area, this is inferior to the frontal gyrus, and Wernicke's area is superior to the temporal gyrus. Now, aphasias are usually associated with CVAs that involve the middle cerebral artery or one of the branches. Language disorders can arise from a variety of injuries and diseases that include vascular injuries, neoplastic injuries, traumatic brain injuries, degenerative, metabolic, or infectious causes as well. But most language disorders are going to result from acute processes or a chronic residual deficit of acute process. So I mentioned Wernicke's or Broca areas. Aphasias are classified anatomically, either Wernicke's aphasia or Broca area aphasias. And they're also can be classified not just by anatomy, but by function. Disorders of fluency, like the quality and the content of their speech. Expressive or motor aphasia, this is known as Broca motor or non-fluent aphasia. So 3 different types of names. And this involves the loss of the ability to produce spoken or written language with slow and difficult speech. So they're having difficulty with the motor movement of making words, but they can still understand. That verbal comprehension is still usually present. Though with expressive aphasia, this is when your words can't be articulated clearly, usually a result of cranial nerve damage or muscle impairment. Receptive aphasia, this is Wernicke's, sometimes it's called sensory or fluent dysphagia, and this is when they have an inability to understand written or spoken language, but when they speak, it's fluent. They have the right muscle coordination to make the words and the sounds, and it flows at a normal rate, but the words and phrases don't have any meaning at all. Anomic aphasia, this is a sensory type of aphasia that's distinguished by the difficulty of finding the right words, naming a person or an object. We also have transcortical type aphasias, and these are rare, and they can encompass motor, sensory, or even mixed type aphasias. They involve areas of the brain that connect the language centers together. And global aphasia is the most severe type of aphasia for obvious reasons, because you are losing both expressive and receptive ability for communication. So you have both expressive and receptive aphasia with global aphasia. This individual will have non-fluent conversation, or maybe they're even mute and they can't speak at all. They can't read, they can't write. They have impairment with the ability to comprehend, to name. Also, with global aphasia, it's usually associated with strokes involving the middle cerebral artery. A type of data processing deficit is acute confusional states, or ACS. And these are transient disorders of awareness, and they result from cerebral dysfunction that can be secondary to drug intoxication, metabolic disorders, or conditions that can affect the brain. In terms of delirium, Now, delirium is associated with autonomic nervous system hyperactivity and typically will develop over 2 to 3 days. This is associated with the right upper middle temporal gyrus or the left temporal occipital junction disruption. And there are several neurotransmitters that are involved, and this can include, but not limited to, a decrease in acetylcholine, excess in dopamine or epinephrine. You might see variable alterations in serotonin as well. This can be an increase in activity. It can also be a decrease in activity depending on the delirium presentation. But we also might see changes in histamine and inflammatory cytokines like CRP, interleukins, interferon, and tumor necrosis factor alpha. They all can contribute to delirium because you're going to have a change in blood-brain barrier permeability, which causes oxidative stress. When we change oxidative stress, this will alter cerebral blood flow. So subsequently, you're going to have alterations in neurobehavioral and cognitive systems. There are metabolic disturbances, and most of these, like hyperglycemia, thyroid disorders, liver, kidney disease, can produce delirium, which will interfere with neuronal metabolism or synaptic transmission. There are many drugs and toxins that also interfere with this neurotransmission function at the synapse as well. We also have what we call a hypoactive delirium, and this is a hypoactive confusional state, but this is more likely to be associated with right side frontal basal ganglion disruption. All in all, an acute confusional state is an acute medical problem. The initial goal is to establish the individual knowing and realizing that they're confused and identifying the cause and the contributing factors. Hypokinetic delirium is when, if we can understand that, it has to be differentiated from depression or underlying dementia. So getting a complete health history, a complete physical exam, lab test, you might even get electrocardiogram, blood, urine specimen, and cerebral spinal fluid to help make that case of what type of acute confusional state your patient may be in. And you may need imaging as well. It usually will manifest as difficulty in concentrating and focusing attention. Delirium will also manifest as restlessness, irritability, insomnia, poor appetite as well. And some patients will even experience seizures with their delirium. They may have unpleasant, terrifying dreams, hallucinations, and delusions as well. Now, in a patient with fully developed delirium, the individual is completely inattentive and the perceptions are going to be grossly altered. The patient in this state will have extensive misinterpretations of language. They will appear very distressed and perplexed, and their conversation is often incoherent as well. You might see tremors, high levels of restlessness are also very common. Violent behavior can also be a presentation, insomnia, dilated pupils, being flushed, and having tachycardia as well. And lastly, there's something called hyperkinetic or excited delirium syndrome, and this is known as agitated delirium. When you see this can actually lead to sudden death. Its symptoms can include altered mental status, combativeness in your patient, aggressiveness, tolerance to significant amount of pain, rapid breathing, sweating, severe agitation. There may be an elevation in temperature, poor awareness, non-compliance, and they will not be able to follow directions, of the medical personnel, healthcare workers, law enforcement. They are unable to become fatigued. Sometimes they have these very unusual or superhuman type strengths. And hypoglycemia, thyroid storm, seizures, cocaine, methamphetamine intoxication can all be associated with excited delirium syndrome. Dementia is a progressive failure of many of our cerebral functions. And this can include, but not limited to, the impairment of intellectual function with the decrease in orientation, memory, language, excessive attentional functions, alterations in behavior. So we might not be able to have good judgment or decision making as well. This is an acquired impairment of intellectual function, and it can be caused by trauma, vascular disease, infection, and progressive neurodegeneration of our brain and nervous system. You might see in your patient agitation, wandering, aggression. You might see a decline in their intellectual behavior. With dementia, the sulci will widen because the gyri are starting to shrink. Ventricles become filled with fluid. You might see amyloid plaques outside the neurons and tangles inside the neuronic cells. With dementia, there may be a genetic disposition, like with Alzheimer's, Huntington, Parkinson's diseases. HIV can also lead to nerve cell degeneration and brain atrophy as well. Dementia is an umbrella term that we use to talk about degenerative dysfunction of a group of cognitive impairments. And we have 4 different types of dementia listed here. We'll first talk about the frontotemporal dementia. This was previously known as PIC disease, and it's a type of dementia and degenerative disease of the frontal lobes. There is a familial association with the age of onset of less than 60 years old, and the incidence is about 15 per 100,000 persons. The majority of the cases will involve a mutation of the gene that encodes for the tau protein, the TAU protein. Lewy body dementia is a disease associated with the normal deposits of proteins in the brain. These proteins are called alpha synuclein proteins, and the deposits, which we call Lewy bodies, affect chemicals in the brain that change our ability to think, move, how we behave, and our overall mood. Lewy body dementia is one of the most common causes of dementia, and at the site of atrophy, you're going to see changes in frontotemporal areas as well. It is a behavioral variant of frontotemporal dementia, and usually you'll see a progressive non-fluent aphasia, semantic dementia. The specific mechanisms of the pathogenesis is unknown, and there's not a specific treatment for Lewy body dementia. We don't really understand the precise cause of LBD or Lewy body dementia, but we think it has to do with genetics as well. We know that there are other known risk factors for Lewy body dementia, though, like Parkinson's disease, connections with our REM sleep behavior, and it is, if we have a disruption in our REM sleep, then this has been linked to higher risks for Lewy body dementia. So even though we have these connections, it's not considered a genetic disease. A vascular dementia, this is a progressive disease caused by a reduction in brain blood flow. And though the pathology can be variable, this really does include a situation where maybe there was a multiple infarcts or hemorrhages that occurred in different parts of the brain related to stroke or small vessel disease. And it's difficult to clinically differentiate, though, from Alzheimer's disease. The symptoms can be much more variable. However, many times vascular and Alzheimer's type dementias will coexist with one another. And I'm going to leave Alzheimer's for now because we're going to go in a little bit more detail in the next few slides. You're often going to be asked to understand the difference between delirium versus dementia. This table is a good comparison of delirium and dementia. You can see that with delirium, the age of onset is usually going to be older adult patients just like dementia. So there is a similarity there. However, you note with the onset, delirium is acute and it commonly occurs during a patient's hospitalization versus dementia, which is usually insidious, acute, in some cases, of stroke and trauma. Associated conditions that can lead to delirium, these are things that you'd want to remember because this could be one of the etiologies for your patient's delirium. Urinary tract infection, thyroid disorders, hypoxia, hypoglycemia, some type of drug or substance toxicity, fluid electrolyte imbalances, renal insufficiency, trauma, or polypharmacy, using multiple medications at once. With dementia, there may not be any other conditions involved, or it could be also with brain trauma. So use this table to go through and to see what is the same versus what is different, and this will help you to answer many types of questions regarding delirium and dementia. We're going to get a little bit more detailed regarding Alzheimer's disease, and it is notable that Alzheimer's disease is the most common chronic irreversible type of dementia. And with it, you're going to see accumulations of amyloid plaques, and tau protein neurofibrillary tangles within the brain. Alzheimer's disease will have plaque formation and loss of basal forebrain cholinergic neurons. Frontotemporal dementias are rare, remember, but they do have some early onset degenerative disease processes that are very similar to Alzheimer's, but still within its own classification of dementia. The exact cause of Alzheimer's disease, or AD, is unknown. Although we have a little bit of understanding regarding early onset Alzheimer's, and this is autosomal dominant, and it's been linked to 3 genes with mutations on chromosome 21. We also understand that there is a genetic risk for late onset Alzheimer's disease as well, and this is related to the apolipoprotein E gene with the allele 4, and this is located on chromosome 19, and it interferes with amyloid beta clearance from the brain, and this is why we get that accumulation of amyloid plaques. It's processed into neurotoxic fragments that are found in the plaques and the tangles in the brain of people with Alzheimer's disease. We also know that there's other types of late onset Alzheimer's, like sporadic late onset Alzheimer's, and this is the most common, and it doesn't have a specific genetic association. However, the cellular pathway is the same as the gene-associated both early and late onset types of dementia. You will see pathologic alterations in the brain that will include the accumulation of extracellular neuritic plaques that contain a core of abnormally folded amyloid beta and tau proteins. You're also going to see intraneuronal neurofibrillary tangles, and again, degeneration of basal forebrain cholinergic neurons with the loss of acetylcholine. So what happens when we're not able to process and clear the amyloid precursor proteins? If we're not able to do this, it's going to result in accumulation of very toxic fragments of amyloid beta proteins that contribute to the development and the progression of Alzheimer's disease. Also, misfolded and aggregated amounts of proteins can trigger an immune response with activation of cells with the release of cytokines that will lead to inflammation. So here we're going to have neuroinflammation and oxidative stress, decreased oxygen and glucose transport, molecular changes in vascular smooth muscle, and within the blood-brain barrier. We're also going to see mitochondrial defects that will alter cell metabolism and the processing of proteins. This includes the amyloid proteins that lead to cell death. Now, amyloid also will be deposited in the smooth muscle of cerebral arteries, and this can cause amyloid angiopathy and disturbance of the blood flow in this area. The tau protein, which is a microtubule type binding protein, in neurons detaches and forms an insoluble filament, and this is what a neurofibrillary tangle is. They contribute to neuronal death. These tangles are flame-shaped. Neuritic plaques and neurofibrillary tangles are the more concentrated in the regions of the cerebral cortex and the hippocampus. And remember, the hippocampus is the area of our brain that's important for memory. When we have a loss of neurons in this area, it's going to result also in brain atrophy, which means we're going to have a decrease in both the weight and the volume of the brain. Specifically, the sulci will widen as the gyri start to thin out, especially in the frontal and the temporal lobes. The ventricles will enlarge then to fill this space. You'll also see a loss of synapses, acetylcholine, and other important neurotransmitters that will contribute to the decline of memory, attention, and other cognitive functions will be lost also. These are all associated with Alzheimer's disease. And you're going to see in more detail on the next slide. Now, you can see in the brain cross-section how this relates to a normal brain versus an Alzheimer's brain. You can see the sulci and the gyrus, the differences. And if you look at an actual brain image, you can see the differences here as well. Here where the ventricles are enlarged to fill the space. You're seeing the amyloid plaques, which will be found in a brain of an Alzheimer's patient. The major clinical manifestations that you are going to witness with dementia is mild short-term memory deficits, and as a disease progresses, you might have a total loss of cognition and executive functions. So initially, the clinical manifestations will be insidious and often attributed to just forgetfulness or being in a more emotional state or other illnesses. And as your patient becomes progressively more confused, and you're going to see that they're going to be forgetful over time, they're going to forget recent events, and then the patient can even become disoriented and more confused, losing the ability to concentrate, lacking the ability for abstract thinking, problem solving, and judgment. This will all gradually deteriorate with the failure and also being able to calculate things like math equations, language, having the visual spatial orientation. The mental status of your patient may change also, inducing behavioral changes. Your patient will become more irritable, agitated, and restless. Mood changes also result from that deterioration in overall cognition. Alzheimer's patients may become anxious, depressed, hostile, very emotionally labile, and they're going to be prone to mood swings. Also, motor changes can occur if the posterior frontal lobes are involved with their Alzheimer's. This is going to cause rigidity and flexion posturing. Weight loss can be significant as well. There is also great variability in the age of the onset, the intensity, and the sequence of symptoms. The location and extent of brain abnormalities is common. Not everyone will progress through Alzheimer's at the same rate, the same pace, and the same sequence. The diagnosis of Alzheimer's is made by ruling out the other causes of dementia. Here you can see the stages in more detail in this organized table, from mild cognitive impairment, early, middle, late stages, and the end stage. At the end stage, cognitively, there's no significant cognitive function, loss of word speech, and functionally, they are not ambulatory, they become bedbound, and our patients are unable to eat. We're going to move on and talk about seizures. And seizures represent abnormal, excessive, hypersynchronous discharges of cerebral neurons. And they come with transient alterations in brain function. Seizures can be focal, they can be generalized, and there's different categories of seizures that include genetic seizures, structural seizures, metabolic etiologies for seizures, immune, infectious, and even seizures of unknown origin. A seizure is a clinical manifestation of a disorder called epilepsy. And this occurs basically due to the excessive firing of the neurons in the brain and fast spread of these neuronic impulses over the brain. And the seizures represent a very sudden, chaotic discharge of cerebral neurons with transient alterations in brain function. They can result from cerebral lesions, biochemical disorders, trauma, or even the disorder of epilepsy. And there are two phenomenons in the pathophysiology of seizure. We're going to have the hyperexcitability of the neuron and hypersynchronization. So let's define these terms. Hypersynchronization means that a hyperexcitable neuron leads to excessive excitability of a large group of the surrounding neurons. When a large electrical impulse is generated to one part of the brain from a focus of tissues, these millions of neurons in the brain will fire excessively in addition to bringing on a seizure. How do we define seizure exactly? By definition, this is an involuntary alteration of behavior with or without loss of consciousness that's accompanied by an abnormal electrical discharge in the brain. And it's really important that we understand that it's not always with the loss of consciousness. Seizure disorders represent a manifestation of disease and not a specific disease itself. So seizure isn't a disease all by itself. It's telling us that there is some other type of disease, and seizure is that clinical manifestation of it. The seizures can be sudden, transient. They disrupt the brain electrical function, which then will show us that there's abnormal excessive discharges of the cortical neurons. Now, epilepsy, again, remember, this is a disease of the brain and will have at least 2 unprovoked seizures occurring within 24 hours apart, and that would help define epilepsy. Also, it could be 1 unprovoked seizure and a probability of further seizures similar to the ones that they've had in this reoccurrence of at least 60% after 2 unprovoked seizures. And this is occurring over the next 10 years. The diagnosis of epilepsy syndrome is also going to encompass these prior determinations. When we use the term convulsion, we're talking about, and sometimes it's applied to seizures, and it's referring to a tonic-clonic movement. Tonic-clonic means a jerky contraction and relaxation, jerky contraction, relaxation movement. And it's associated with only some seizures, not all seizures. So it is a misunderstanding to think that all seizures come with loss of consciousness or this tonic-clonic jerky contraction and relaxation movement. Epilepsy has been estimated to have affected about 4.3 million adults and about 750,000 children here in the US. And seizures in children are presented more in depth in your book. It talks over the PED section, if you're interested in hearing a little bit more about that. What about conditions that are associated with seizure disorder? And you can see with this chart the structural or metabolic causes of recurrent seizures in adults versus older adults. So, adults is defined as anyone between the ages of 18 to 35, and older adults over 35 years old. So, the probable causes for a young adult would be alcohol or drug withdrawal. So, think of drugs like barbiturates or benzos. If there's a brain tumor, illicit drug use like cocaine and amphetamines. There may be some post traumatic brain injury, or it could even just be idiopathic. With older adults, it can also be from some of these similar things, including major depression, degenerative diseases like Alzheimer's or multiple sclerosis, as well as a stroke, aneurysm, or AV malformations. When we think of seizures, we have to classify them in terms of the etiologic factors and the type of seizures and the phases. So first we're just going to talk about the etiologic factors here. So again, this is just in general. You saw in the last chart more detail specific to age groups, but could be metabolic, congenital, genetic. It could be a perinatal injury, postnatal trauma, perhaps, myoclonic syndromes, infection, tumors, vascular diseases, and substance abuse. In terms of classifications, we classify seizures by their clinical manifestations, the site of origin that is affected, and then firing out to other regions, what your EEG is correlating. And your EEG is a type of study that we can put electrodes on the brain and understand where the firing or hyperactivity is originating from. And then also it's classified by the response to the therapy. We can classify them by either determining if it was a focal seizure, one area, generalized, kind of all over, if it was status epilepticus, which is a acute emergency of seizure, and then epilepsy, which is the disease in which you have multiple reoccurrent seizures. We're also going to talk about more in depth the phases of seizures, starting with the prodroma phase, the tonic phase, the clonic phase, and the post-ictal phase as we progress through these slides. So with the focal seizure, we know that this type of seizure originates in one area of the brain. And usually aura is very common to precede when we have a seizure. And aura is this state in which your patient just feels unwell. There may be changes in hearing and sight, sensation. You're going to, in terms of motor differences, the patient may have a stiffening of the body muscles and they may fall. Loss of consciousness. They can also have this type of change in their sleep. Tonic seizures are more common in infants and children, although we also have focal atonic seizures. And atonic seizures are sudden, they're brief, and you'll have a loss of muscle tone, so you'll be hypotonic. They can also fall. And usually with atonic type seizures, there's no loss of consciousness. Again, the tonic type seizures, we're more at risk for the loss of consciousness. Now, myoclonic seizures, or this movement, are sudden, brief, shock-like jerks or twitches. And this can happen in both the upper and the lower appendages, the arms and the legs. Your patient may drop things. Usually there's no impairment of consciousness, and it's very frequently going to occur right after waking. Now we combine tonic and clonic. This is the abrupt loss of consciousness. You'll have the tonic motor movement, which is the stiffening of the body, and then shaking, which is the clonic part. And this can begin with a sudden cry, a loss of bladder control, biting of the tongue, and it usually only lasts about 2 minutes. And then there's a period of confusion that follows, a period of agitation, and then severe fatigue. Headaches and soreness are often very common afterwards as well. Also, in terms of hypermotor, this is bimanual or bipedal motor activity. What you'll see in this situation is your patient will look like they're kicking and they're thrashing around. They may be clapping or rubbing both of their hands together. They may be hugging or bringing their arms to center. And sometimes there may be some sexual automisms and also autonomic changes with or without preserved awareness of it happening. So with non-motor types of manifestations, in terms of sensory, your patient may describe numbness, tingling, burning sensations, flashing lights, and auditory experiences. Cognitively, they may experience aphasia, hallucination, changes in memory or attention. Emotionally, they may have a lot of fear. They become angry, they cry, they become agitated, they may burst out laughing or experience paranoia. Autonomically, you might see blushing of their skin or even pallor, so two different things. You can see increased or decreased heart rate. And in terms of ventilation, it could be either hyper or hypo. You also will have some nausea with this as well. Now, not all seizures have, again, that loss of awareness. With focal seizures, most often they can recall what's going on. There's responsiveness and consciousness are intact. But sometimes you have a loss of that. Impaired awareness can also occur where you don't understand what went on. There's a loss of consciousness. They are in a very vague and dreamlike state. Now contrast that with generalized seizures. And these are seizures that originate in both sides of the brain and they're originating simultaneously. And this can include tonic, atonic, clonic, myoclonic, myoclonic atonic, clonic tonic, all types of activities. You can see with epileptic spasms, we used to call these infantile spasms. This can actually happen between the ages of 3 and 12 months of age more often, and it can be idiopathic, genetic, it can be a result of metabolic disease or CNS type injury. And you'll see these spasms clustered in about 5 to 150 times per day. And you're going to see episodes of both flexion and extension that will involve your patient's neck, trunk, and extremities. And the manifestation can range from just a little bit of a head nod to very violent, uncontrolled body contractions. Epilepsy syndrome is the disorder that displays a group of signs and symptoms that occur collectively, and they're characterized or they will be indicating a particular condition, usually associated with a genetic or developmental cause. Neonatal seizures, these can be seen in our neonates by manifesting rhythmic eye movements. It looks like they're chewing. They might make some movements that appear like the baby is swimming. Common in neonatal seizures, there's 5 types. There's subtle, tonic, clonic, myoclonic, and the non-paroxysmal repetitive behaviors. And you can see the percent that make up those type of neonatal seizures. You can continue to go on through this list. Something else that I wanted just to bring to your attention is febrile seizures and pseudo seizures. Now, febrile seizures, these are common in children younger than 5 to 6 years old, and they only last a few minutes, but they can cause a lot of damage if not recognized, and usually these convulsions will be associated with very high fevers, and it's really important to bring them in to receive care, and you need to exclude meningitis as the cause of the seizure. Usually, if a patient has a simple febrile seizure, it doesn't mean that's going to develop into epilepsy. And pseudoseizures are a non-epileptic phenomena. It looks like epileptic seizures. However, the diagnosis requires video EEG. So not only will the electrodes be on the patient's head, but you're monitoring them with video to see what's happening as you're assessing the brainwave patterns. And usually you'll see with the EEG, everything is normal during the clinical events. And frequently, pseudoseizures will occur in the setting of child abuse, unfortunately. So here's this term again that I want you to know, status epilepticus. And this is defined as a seizure within 5 minutes or more of continuous clinical or electrographic seizure activity. So you might not see it clinically, meaning, if you're looking at your patient, you might not notice. However, their EEG would show otherwise, that they're having a seizure, that there's hyper excitability of the brain neurons, or they're having recurrent seizure activity without recovery between the different seizures. And this is the definition of status epilepticus. If you have epilepsy, you may have seizures repetitively. A seizure that lasts longer than 5 minutes, though, or having more than one seizure within a 5-minute period without returning to the normal level of consciousness between episodes, this also can be defined as status epilepticus. Okay? Your textbook says that status epilepticus is continuing or reoccurring seizure activity in which recovery from the seizure activity is incomplete. The seizures are unrelenting and can last 30 minutes or more in totality. The other forms can evolve into status epilepticus. So the other types of seizures that we've talked about, if they don't resolve, they can turn into status epilepticus. It is a medical emergency and it does require immediate intervention. You will learn more in your med-surg class what those interventions are, but this is a medical emergency. And then I just wanted you to see the framework for the classification of epilepsy. And hopefully this slide can help you just to better understand this terminology. Now, epilepsy is considered to be the result of the interaction of very complex genetic mutations with environmental effects that cause the abnormalities within the synaptic transmission, an imbalance in the brain's neurotransmitters, or the development of abnormal nerve connections, or the loss of nerves after a type of injury. The International League Against Epilepsy, they propose 6 groups of categories that can cause epilepsy. And you can see them there on the right: genetic, structural, metabolic, immune, infectious, or unknown etiology. Now, the neurons can become hyperexcitable and are more easily activated in states of hyperthermia, hypoxia, hypoglycemia, hyponatremia, or repeated sensory stimulations. During seizure activity, oxygen is consumed at a very high rate. Your brain is going out of control, and it's going to consume oxygen at a rate of about 60% more than what it's used to. And although the cerebral blood flow will increase at this time, the oxygen is rapidly depleted along with the glucose. What will occur is an accumulation of lactate in the brain tissue. With continued severe seizure activity, you will have the potential for progressive brain injury and irreversible damage at some point. If the seizure focus in the brain is active for prolonged periods, you might see a contralateral deficit, and it can cause more seizure activity, especially and particularly with the focal type seizures that affect more of the temporal and the frontal lobes. Let's now move on to the phases of seizures, and you can actually see now um, while the patient, before the patient may have a seizure, during the seizure, and what happens after the seizure. You do want to know and be able to differentiate between this terminology. The prodromal phase of seizure, this is when you might notice early clinical manifestation, such as malaise, your patient may complain of headache, become depressed, and this can be a few days prior or even can happen, a few minutes prior as well. The term aura, or this aura phase, is usually experienced with a focal seizure, and a patient may describe a peculiar sensation, like much like actually like the aura of a migraine. They might have visual, auditory changes, gustatory changes as well. They may feel dizzy or numb, or even describe it as just feeling funny. The ictus phase, this is the episode where the seizure is actually happening. The tonic phase is where you have muscles contracting with excessive muscle tone, and the clonic phase is when you have alterations in the contraction and the relaxation of those muscles. And lastly, the post-ictal state is the period directly following the seizure activity. And now we're in the cessation of seizure activity. No more movement, no more hyperexcitability. When you see a person in post-ictal state, usually they have headache, confusion, aphasia, memory loss, and paralysis. And this can last anywhere from hours to even days. Patients in this post-ictal state are known to be in deep sleep. This is very common as well. And again, you'll learn more about the management in your med-surg course. However, it is important in this situation to get a very thorough health history. You want to get a baseline of understanding, like lab tests, blood, urine, glucose, calcium, BUN, creatinine. All of those things are going to be important, as well as EEG. If there's a time that you could get a baseline EEG, that would be even more informational. Sometimes you can get an EEG with a functional MRI, and this can help you identify neural networks that are involved in the epileptic activity. It will also be very crucial for you to differentiate a generalized epilepsy from a focal epilepsy, because this is going to help you determine what type of treatment and also the prognosis for your patient. My last slide here, you can see is credited to the blog below here. And they use this popular cartoon character, Homer Simpson, to help you understand the phases of tonic-clonic seizure. And so you can use this to try to remember the prodromal versus the icterus phase, the tonic-clonic phase, and then the post-icteral phase. So try to remember this schematic here to further understand the phases of seizures that were shown on the previous slide.